Morning, everybody. This is Advanced Patient Care Theory 2, Unit 2, Part 6, Complications in Labor and Delivery. And I got to tell you, this is one topic that scares me, quite frankly. So we're going to talk about premature rupturing of the membranes, breech presentation, prolapsed cord, limb presentation, multiple bursts. Sorry, these bullet points are a little out of sequence. Cephalopelvic disproportion, so that's usually patients with babies with hydrocephalus who have unusually large heads, but that's a rare occurrence here in Canada these days. Precipitous delivery, shoulder dystocia, one of the more common complications, and meconium staining, postpartum hemorrhage as well. One of the reasons why it's rumored we're going to be getting oxytocin at some point, maybe in the next year. Uterine rupture, uterine eversion, and pulmonary embolism, either due to amniotic fluid or other causes, but amniotic fluid being the one we're more likely to see in a pregnant patient. Hang on a split second here. Sorry about that. I muted my mic for you guys, but I have a feeling that's going to come through in the recording. So let's talk about premature ruptured membranes. So that occurs before the onset of contractions in about 10% of deliveries, and can happen as a gush of fluid, but is usually a trickle. And more fluids noticed when lying down rather than standing, because the baby's head actually blocks the cervix when mom is standing. And the amniotic fluid should appear clear or slightly yellowish or amber color. It should have a faint sweet smell, which can help differentiate it from urine. And contractions usually start within 12 hours of the membranes rupturing. After 24 hours, there's a greater risk of infection to the baby. That's a concern. Let's see here. Hang on, my slides have stopped loading here. Stand by. Got a slight delay. It says loading 4 of 32 slides. So when we see meconium staining, the question is, when do we suction? When do we not suction? So again, the fetus will ingest amniotic fluid and excretes it every day through the kidneys. Meconium is the first stool, and if the fetus is in distress, it may actually defecate in utero, and this results in a greenish blackish color meconium stained amniotic fluid, which tends to be very sticky, tarry in texture, and may be aspirated by the fetus, and that can cause significant respiratory distress. So the general rule now is when you deliver the head, we used to routinely suction the mouth and the nose. Now we no longer do that unless there is significant amount of meconium stained amniotic fluid in the mouth, in which case we suction the mouth first. And so the photo on the left is what we expect, and we just let the baby drain fluids as you might just wipe off the face, but we don't routinely suction anymore. The dark tarry stuff down below is meconium staining, and that's what meconium staining looks like anyway. So if there is significant if the baby is born flaccid and there's significant meconium in the mouth, then before we dry and stimulate that baby, we're going to clear the airway. So you might get one person to just throw a warm towel around the baby without actually any stimulation, and we're going to suction the hypopharynx, maybe intubate the trachea using a meconium aspirator, which is this thing. Whoopsie. Hang on a second here. This thing here. So it attaches the ET tube, and then the suction catheter attaches to there, and we go into the trachea with the ET tube, and then seal that suction port off to suction out the trachea. And the suction should be set to between maybe negative 60, negative 80 milliliters of mercury for the purpose of suctioning a neonate. So you want to suck out as much and as quickly as possible prior to stimulating the baby, and continue until the airway is reasonably clean, and then follow that with positive pressure ventilation. Probably without oxygen, but I don't think anyone would criticize you if you did it with oxygen. So that's what the meconium aspirator looks like. Let's talk about different presentations. So breech presentation is buttocks first, and do we transport or do we not transport when you've got a breech presentation? What do you recall, those of you who've taken the emergency delivery course? See, Chris is typing. Thank you, Chris. Yeah, we can deliver breech. You're saying through. I hear an open mic. Someone's.
Say, Rob, when delivery is imminent.
When delivery is imminent, yeah, good. So if the delivery is not imminent, then we transport. So some pre-hospital techs still suggest not suitable for delivery. Mom should be transported, but the answer is we are transporting. And I'm going to pause this video for a second because I think I might, or this slide presentation for a second, so I think I might have a video. Let me just double check on that. Okay, so yeah, I couldn't find my videos, but if I find them later, I'll bring them up. So they're variation breech presentations, and they're described here in these images here. So complete breech, incomplete breech, and frank breech. Where we might not deliver is if there's a footling breech. So if we just have one foot sticking out, mom is generally put in the hands and knees positions and transported. So if the body delivers and the head of the infant is stuck and starts to breathe with its face pressed against the vaginal wall, one of the things we're going to do is we're going to form a V formation with the fingers up against the infant's zygoma, and try to create some space between the infant's face and the vaginal wall. And usually what they do is they just raise the head all the way up to like get mom into McRoberts position, so hands, knees to chest, and then lift that baby's abdomen and chest straight up and deliver the head that way. But if you're unable to deliver, you would continue transport while keeping the mouth away from the vaginal wall to make sure the baby continues to breathe. So that's what I'm talking about. As just out of curiosity, I know some of you have delivered, one or two of you have delivered babies in the field. Has anyone had to deliver a breech delivery? I know of one medic who's done it, and he said it went fine. Wasn't nearly as big a deal as he thought it might be. Anyone in this group? No? Okay. Anyone know of someone you work with who's done it, and you can describe what happened? Yeah, me too. I'm with you, Chris. Okay. Now I've got here watch the videos, but I don't think I have the videos. If you'll wait, if you'll give me a few seconds, I think I'll take one more look to see if I can find those videos. Let's see if this works here. Seems to be a problem with your internet connection, or a YouTube video is blocked. Well, that's not good. Let's try something else here. Stand by. Alright, so if you watched the video, great. Let's talk about prolapse chords. So this is where, oops, not sure what happened here. Again, if you're, let's see, watch the video. Okay. So this is when the umbilical cord obviously precedes the rest of the fetus. So the presenting part is the, whoever's moving the slides, please don't. So we want to elevate the hips, administer O2 to keep warm. If the umbilical cord is seen in the vagina, insert 2 fingers and raise the fetus off of the cord. Do not push the cord back. Now, here's the interesting part. We had a discussion about this recently at a CME, and one of the instructors was saying, have mom push the cord back in. So, but the midwives had told us to wrap the cord in a sterile moist towel and just transport, keeping the head off of the cord. So that might be actually inserting the hand inside the vagina and keeping the head off the cord. Now, to do this, hand and knee position is not a position that any service would recommend because it's virtually impossible to secure the mum, but you may not have a choice. Alternatively, you might be able to put mum in Trendelenburg. Now, I had a discussion with about this with the OB nurse instructor here in the nursing program, and she said Trendelenburg probably isn't going to cut it. So I guess it'll be a judgment call on your part. So elevate the hips, O2, and keep the baby's head away from the cord. If at all possible, wrap the cord in a sterile moist dressing and transport. So you can see here where the head is being kept away from the cord. Continue pressure on the baby's head. This is the ideal position for a prolapse cord. So gravity keeps the baby's head away, but not ideal for transport, unfortunately. Trendelenburg may be your only safe way to secure the mum. So we talked about this. Other abnormal presentations. I think we're missing a slide here. Multiple births. Follow normal guidelines. So call for additional help and equipment. Obviously, in twin births, labor starts early and babies are smaller. So we can keep that in mind. We want to prevent hypothermia as much as possible. Sometimes that means getting dad to throw some towels into the dryer to heat them up. So when babies are delivered, we can get them wrapped up in a dry towel right away. Probably one of the most important tasks is when you dry and stimulate the baby to get rid of the wet towel and then wrap the baby in a warm, dry towel. For cephalopelvic disproportion, these are usually the infant's head is just unusually large, or they've got hydrocephalus, which is even more concerning. So oversized fetus, hydrocephalus, conjoint twins, fetal tumors. Hopefully mom will know if there are any anticipated complications before all of this takes place. So if not recognized, can cause uterine rupture and usually requires C-section. So give mom O2, initiate transport, maybe start an IV en route. This is hydrocephalus and not something that we see in developed countries. More likely to see this in underdeveloped countries. So precipitous delivery. So occurs in less than 3 hours of labor, and usually happens in grand multiparous. So if I recall, I think the definition for grand multipara has had 5 previous births. Someone can correct me if I'm wrong on that one. I think that was the definition in the old BLS standards. And there can be trauma, tearing of the cord, maternal lacerations. We're going to be ready for a rapid delivery to control the head, keep the baby warm. And so multipara is given birth 2 or more times. Grand multipara, that's it, given birth 5 or more times. Okay, I couldn't remember the definitions, but there you go. Shoulder dystocia, and I think I have a video for this. So this is where the anterior shoulder, this shoulder here, gets stuck under the pelvic bone, under the symphysis pubis. And so when we deliver the baby, the objective is to lower the head so that the shoulder comes underneath the symphysis pubis and delivers. But if that doesn't happen, if the head turtle sort of goes out and pops back in again, you're likely to be dealing with a shoulder dystocia. And you've got, maybe 5 minutes max to get that baby out before the risk of fetal death. This is why I found labor and delivery even more frightening after taking the midwives course. So the shoulders are larger than the head, and that's the part of the problem. Then they, make it a turtle sign where the head comes out, then retracts. The head may stay out, but the shoulder is stuck against the symphysis pubis. And that's the symphysis pubis right here, by the way. That's what it looks like on an X-ray. And so in the shoulder dystocia, first thing we do is we lift mom's legs knee to chest, control mom's breathing, and then we do anterior shoulder disimpaction maneuvers by applying suprapubic pressure down and laterally. Alternatively, we can try a rotation, which is a Rubens or wood screw, which is a turning of the baby over to the other side, or roll the patient over on all fours. But all this has to be done within about 5 minutes. Otherwise, risk of permanent hypoxic injury. Now, I'm going to try to bring up a video. Let me just pause this recording for 2 seconds here. Okay, so yeah, we don't do episiotomies. We'll move on here. So postpartum hemorrhage, defined as a loss of more than 500 cc's of blood. So we treat for shock. Sorry, these things are out of order. So transport, a couple of large bore IVs, SpO2, O2, ECG, fluid resuscitation, PRN. Uterine rupture. So this is a tearing or rupture of the uterus with severe abdominal pain, and the abdomen is likely to be very tender and rigid. Fetal heart tones may be absent, but we're not going to assess for those. Treat for shock, give high flow O2, fluid resuscitation, transport immediately. Uterine inversion, so it's when the uterus turns inside out after delivery and extends through the cervix. Blood loss can be 800 to 800 cc's, and we want to begin fluid resuscitation. The recommendation is that you make one attempt to replace the uterus. So take ideally a sterile gloved hand and push the uterus back in. If that fails, then cover the uterus with towels moistened with saline and transport. Pulmonary embolism. Not a whole lot we can do about this other than to provide, sorry about that, is that a little bit better? Other than to provide supportive care. And so this is a venothromboembolism, likely due to stasis of blood, coagulation during the pregnancy, usually in the lower limbs. So happens about once every 200 to 1,400 deliveries. So one or two, that's quite a range epidemiologically. So presents with sudden severe dyspnea and sharp chest pain. O2, PPV, PRN. Just remember the chest is going to be clear in a pulmonary embolism because it's a block of the vasculature. It's not a block of the air spaces. IV, monitor closely, transport. Amniotic fluid embolism, same principles apply. So it's a rare occurrence. 1 in 8,000 to 30,000 pregnancies. You get amniotic fluid, fetal hairs, other debris enter the maternal circulation, and they present with hypotension, dyspnea, seizure, sharp chest pain, cough, cyanosis, fetal bradycardia. Again, we're not going to assess that. Pulmonary edema is a possibility, usually a localized pulmonary edema. And cardiac arrest. I had a patient who came in on a medevac from up north with an amniotic fluid embolism. She was unresponsive and shocking, and we provide supportive care. So That's it for that presentation, and we are actually done for the morning because we're ahead of schedule by about 2 weeks. So we'll just carry on to the next unit. Next unit is Unit 3, I think, and we're not due to cover it until week 5, and we're only at week 3 right now, so we're a little ahead of the game, which is good. So it'll give us a little bit of time to do some review. Any questions before we call it a morning? I don't know the date off the top of my head. You'd have to look at the syllabus. But the first test is online for both courses. Same with the assignment. I'm sorry, I'm teaching 6 classes, so I couldn't tell you the assignment dates off the top of my head. Just look at the syllabus. So Roger is saying February 26th is the first test. 28th for the assignment. There you go. Now the assignment for Advanced Patient Care Theory is 2 parts, right? Don't forget. So the first part is you send an audio recording of a report plus the written transcript, and then wait till you get feedback before you submit the second audio report. Yeah. Anyway, check the syllabus to confirm. That's what I would say.